Hi, everyone. You're all very welcome for our second session of today. We're celebrating Science Week together. My name is Elisa. I am from the RCSI Department of Obstetrician and Gynaecology. This event is part of our initiative called Bias, Inequalities in Women's Health and Research, through which we aim to highlight research in women's health and debunk some myths and tackle biases that still surround women's health and research. We're funded through Research Ireland through the Science Week call. This event will be filmed. With us today, we also have our lovely Robin here, who's gonna live sketch this session. Looking forward to the final result. The first one was amazing. So thank you all for being here and celebrate Science Week with us. And that's about it from me. Let's get started. Claire.
This one's a lot better. Good stuff. Thank you so much. So yes, my name is Claire O'Connell. I am a science journalist and I'm delighted to be moderating this discussion today. We're going to be learning about what is changing for people on their fertility journey and how to get support and guidance when you're on that journey. First, a little bit of housekeeping. So if everybody could put their devices to silent, just double check that that setting is on and check your nearest exit as well. So that's the housekeeping done. And as Elisa mentioned, this is an event that's part of Science Week, which is supported by Research Ireland. And the theme of Science Week is Then, Today, Tomorrow for this year. We're joined by a stellar panel today to talk about fertility, and I'm going to introduce them all just briefly, okay? So we have Caitriona Fitzpatrick, who is chairperson of the National Infertility Support and Information Group. Laura McCaffrey is a specialist pregnancy counsellor with the Irish Family Planning Association, and Laura, you have particularly a lot of training in the areas of fertility and pregnancy loss. We have Jade Kirwan, who's a clinical nurse specialist in the Fertility Hub at the Rotunda. And we have Dr. Edgar Mocanu, and I am going to give you his title, and I apologise, we could be here for the hour, because he is Honorary Clinical Associate Professor of Reproductive Medicine and Surgery at RCSI University of Medicine and Health Sciences and subspecialist in reproductive medicine and surgery and consultant obstetrician gynecologist at the Rotunda. Congratulations, Edgar. And I must apologize to Orla, who's doing a super job on ISL interpretation for that particular title. Thank you, Orla, for your work today. But I'm joking, of course. So just to get to know our panel a little better, I'd like to ask each of them about what they currently work on. So Caitriona, tell us a little bit about the work you do in this area.
Sure, and thanks so much for having me here today. Well, NISIG is a charity basically run by volunteers, so I'm here in a voluntary capacity, and we provide support and information to people on their fertility journey. Our expertise, a short title, but we're all experts by experience. So I have done 8 rounds of fertility treatment myself. So when I'm talking to someone, I have a very good idea of what it's like to be in their shoes, as good as anyone can, having done my own fertility journey over a number of years, which I finished 5 years ago. So so anybody involved in NISIG, when you speak to them, when you pick up the phone, the support groups that we do, it's a peer-to-peer support. We're not medically trained, or we're not counsellors, but we have that lived experience, something that's actually coming in a lot more in lots of medical areas. So NISIG basically has a support line, we have a website, and we do peer support meetings. We do a huge amount of advocacy. We were very involved in advocacy around the AHR legislation. It's really important for us to see that legislation now be commenced and for the new regulatory authority put in place. And we also did a lot of advocacy in relation to the publicly funded IVF. And we're really keen to see that expanded and see the hubs expanded as well. So really, I mean, we're coming at it from the patient perspective.
Brilliant. Thank you, Caitriona. And there's a lot we will be exploring within that as well as we get through the panel. So Laura, tell us a little bit about yourself and what you do.
So, hi everybody. I'm Laura McCaffrey, and as you said, I'm a specialist pregnancy counsellor with the Irish Family Planning Association. So, the Irish Family Planning Association have been around since 1969, founded by 7 volunteers, and since then they've kind of been at the forefront of, I suppose, the fight for sexual and reproductive rights, both nationally and internationally. For aeons, we have provided counselling, which has been HSE funded, what used to be termed their crisis pregnancy programme. And that has shifted slightly. And now actually we still provide crisis pregnancy counselling, which takes the form of all types of crisis within a pregnancy. But we're also now providing counselling from referrals through the fertility hubs, the recurrent loss hubs, and complex menopause hubs as well, which is great to see. So at the moment, it's HSE funded. It's an 8-session model. It can be either used by a couple or individually. If we feel there's a need for a couple to have individual counselling, we can organise that for them as well, and we will request that that is funded for them too. We have satellite hubs all around the country, so we can offer sessions online, by phone or in person. And we also do evening sessions via telehealth, which is great. We currently don't actually have a waiting list, which is super, because there's a lot of demand for counselling services. So to be able to have a referral, the referral comes in once it's processed, depending on your availability, we aim to see really quickly. You have a year to use the sessions. They don't all have to be used. Some people might only need 1 or 2, but the full 8 sessions are there if needs be. So we'd love to see it expanded out. At the moment, the fertility hub counselling is offered to couples who have finished their HSE funded journey but have been unsuccessful. We would love to see that expanded to all couples on their HSE funded journey. So fingers crossed.
Great. Thank you, Laura, because, and I'm sure we'll talk about this. There are a lot of challenges with mental health at all stages of the journey, probably. Jade, you're in the Fertility Hub in the Rotunda. Can you tell us about what you do there?
So I am one of the 3 CMSs, or the clinical midwifery specialists, that work within the hub. Our primary role is to do initial consultations with couples first, provide initial investigations, whether it be scans, bloods, providing semen analysis, and then we would refer them on then for their doctor's appointment afterwards. So we're kind of the first initial contact that the patient will have within the fertility hubs.
Okay, great. And Edgar, you would work closely with Jade in this process. What do you do?
Claire, thank you for being here tonight. Thank you for the introduction. I think it's a wonderful opportunity. Thank you to all of you for being here. I pick up the pieces after the patients have been firstly seen by our nurse specialists, or tests being organized, and try to wrap it all together and tell them what's wrong with them, what are the tests we might need to do, what treatments might be available, do they need IVF, would they ever be able to have a child? Sometimes the answer might be no. And do surgery. If they need operations, bring them in for either simple procedures like a look inside the uterus, or more complex procedures like removing a fibroid or opening tubes or treating endometriosis. Yeah.
And Edgar, I'm curious to know what you are seeing developing in the field of fertility and being able to support people on that journey from a medical perspective. What kind of procedures and approaches do we have now that maybe we didn't have 20, 30 years ago?
I think it's important to differentiate between the tests, diagnosis, and treatments that we provide at the present moment in the Rotunda, and what else is being provided apart from what we do. So we'll be not necessarily the first port of call, but we'll be probably the last port of call before IVF. So that means GPs could organize tests and give a rough idea to our patients what might be wrong. Then we can bring them to the next level, where we can use keyhole surgery to look inside a patient's abdomen to see that she might have some scarring around the tubes, to treat that, to identify endometriosis and laser it away, to be able to place a very fine telescope inside the woman's uterus without a general anesthetic, just local anesthetic, and remove fibroids, remove polyps, look at the structure of the womb, and maybe need to do some surgery to return it to normality. So these are things that weren't possible. For example, this therapy called outpatient hysteroscopy was not something that was offered even 10 years ago. But this is a walk in, walk out. Within half an hour, the patient is in, goes home, her problem sorted. In terms of investigations, we definitely do a lot of genetic testing. So we're now understanding better the background, particularly on the male side. Why is the man not producing good sperm? So we can do some genetic tests to identify. And then depending on the diagnosis, we can help them move on and have different forms of therapy, namely ICSI or testicular biopsy or so on. And apart from that, I think they are the main developments, apart from the fact that a larger and larger number of patients want to access the service, of course, mainly due to the fact that the HSE now is paying for assisted reproduction, and that has created a very large influx of need.
It's created the ability for people to access these as well. Jade, do you find people are surprised when they come to the Fertility Hub at how much is available to them?
Yeah, I definitely think we definitely see there's a lot of people that have come to us that just thought they were coming for investigations, and then at your initial appointment we'll give kind of a brief rundown of what we think that you could be eligible for in the future. And I think people are surprised by what the HSE will cover in terms of your round of IVF, ICSI, or if you're eligible for IUI, they'll do 3 rounds of IUI first.
Can you explain what IUI is?
So an IUI is in intrauterine insemination. So essentially we would do a controlled ovulation induction cycle, and then around the time of ovulation, the clinic that you choose to attend to will wash down essentially sperm into the uterus.
Okay. So this is one of things that people can avail of almost instantly.
It wouldn't be instantly, yeah. So initially, when you come through the hub, it's more of a triage system. So we see people in terms of what needs to be done. If everyone has their investigations done, they can go straight and see the consultant first. If they need to have investigations done first, they come and see us. When they see the consultants, then if there is a clear indication that treatment is indicated, they will then be referred on for, say, an IUI treatment if they're eligible, or if not, then it'll be something like IVF or an ICSI cycle if it's indicated. Okay,
great. I suppose this is when people are at the Fertility Hub, they are at a particular stage in their fertility journey. Broadening out from that, it's a longer journey for the people who are involved in it. Laura, I'm curious to know what kind of mental health challenges there can be for people on a fertility journey and what kind of supports they can access.
So the mental health challenges can be huge. They can range from stress and anxiety, over your health, treatment outcomes, depression. That can be either feelings of sadness to feelings of despair. You can suffer relationship issues, low self-esteem. The list really is endless. One that we don't really talk about, but which I think is really important, is we tend to see, a high prevalence of PTSD for people who have gone through fertility. So that's post-traumatic stress disorder. And particularly we see that where there has been pregnancy loss. Like studies have shown, the largest study in the UK showed that in relation to pregnancy loss, showed that 18% of women exhibited symptoms of PTSD 9 months after their loss. So that's nearly 1 in 5, and we don't talk about it. And I think that's really important. So the supports then would be organisations like NISIG, which is a vital organisation, places like the IFPA, where we do fertility counselling, and then also organisations like IFPA, the Irish Fertility Counsellors Association. So they would all be private therapists who are specialised in all areas of fertility. You have to have done additional training to be a member of IFPA. So there's some of the supports available.
Okay, brilliant. Thank you, Caitriona. Would you like to expand on that? What kind of supports people might be able to find from each other, that peer support that you enable?
Yeah, and I think a lot of people, when they find themselves at the door meeting someone like Jade, they're so surprised to be there. It's really just not something you expect. Lots of times they're probably, you know, maybe slightly older and at a time in their lives and they've achieved an awful lot. They are having great careers. Everything is going as planned. They've met a life partner that they'd like to start a family with, or they want to start a family on their own. And it's such a shock that we just have such a history in this country of don't get pregnant and be careful and all that. And you know, now we've got really good education and you know, contraception is widely available, but the other side of the conversation, like lots of people I know would have had in their 20s knew they wanted to have a family. Some of them wanted to have a big family, but they weren't really having that conversation with the partner, or they weren't thinking about the lifestyle choices they would make around it. And so, yeah, it's one of the biggest things that when people would come to one of our meetings, they're just so surprised that they're sitting there on a Saturday morning with a group of strangers talking about not being able to get pregnant.
Yeah.
And they really are unclear about sort of the, almost like the technicalities of it. I mean, you know, and same with people's partners. And I came to the earlier session and Dr. Kleena mentioned that she wished we were talking about health as opposed to women's health. And there's a bit of that here as well. Men are very much affected by this, but it's seen as being very much a women's issue. And, you know, then they're far behind going, how does all this work anyway? And they have to kind of get on board with that.
Yeah.
But look, I mean, in saying that, the fertility hubs have been such a brilliant addition. You know, that the fact that when people contact us, the first thing we'd say is, have you spoken to your GP? Straight away, get your GP to see if they can refer you to a fertility hub. That's a great port of call where to start, and then on from there. And it's you know, it's great that you can get that for free before you kind of know, well, what else do I need to get done? But certainly, yeah, like a peer support service is just somebody who's in the same position as you. Or people come to the meetings who, when we run support meetings, maybe every quarter, either in person or online, and some people won't have gone near IVF or anything like that yet, but they're just kind of wondering and they don't really want to go into the online forums. Whereas other people are nearly close to going down the route of surrogacy, and
Right.
you know, so it's quite a wide spectrum of people that would look for support.
Right. Okay. And there's a huge demand for it, obviously.
Well, I mean, the demand is kind of hard to quantify because there's 3,100 people now going through the public funding, but you know, so that's what's being counted. But I guess we're not publishing stats from every clinic. So I mean, and we're not publishing stats from people going abroad. So what do we know? How do we know what the demand is?
Okay. Fine.
How many people went abroad and had IVF or done last year? We don't know. Like who's coming back and putting their hand up when they come back in saying I decided to go abroad for it.
Okay.
So I mean, that's a really big thing that we need. Is we need to know the numbers, because how can we plan services without numbers?
Yeah. Very true. Very true. If anybody in the audience has a question for our panel, please do raise your hand and we'll get a microphone to you. But I suppose, you know, Laura, maybe I can ask you about sometimes the feeling, and maybe this is something people don't talk about much, but what about the feeling that somebody might have if they're on a fertility journey and they see their friends, suddenly their friend is pregnant, or, you know, their brother and the wife are having a baby or something. What about those kind of feelings?
Yeah, so that's not talked about. And jealousy and envy are really common. They are natural human emotions. You are allowed to feel them. And I cannot state that enough. It's so natural. If you're TTC trying to conceive and somebody maybe does a big announcement, they, you know, oh, we didn't even try and we got pregnant. If you experience envy or jealousy, it's a signal from your body that this is something that's really important to you and you're really sad that you don't have it. And that is fine. So the first thing to do is acknowledge it. It's there. Powering through it won't help. Stop, take a breath. It's there. You are allowed to feel it. A way that can be really beneficial in helping cope with envy and jealousy when you're TTC, there's a few things. One of them, set boundaries with your friends. If you know friends are also trying to conceive, have the conversation. How do you want to receive the news? Some people like maybe a phone call. I would always think a text is better. If you receive a text, you can read it in your own time. You don't have to put on a brave face. You don't have to say congratulations straight away.
You can pretend you didn't see it for a while.
Absolutely. Yeah, you don't have to respond. You know, turn off your read receipts, you know, like turn off your last online. You can hide from it because you're allowed to hide from it. It's so natural. And learn how to set boundaries. You are allowed to say no. You don't have to go to the baby shower, the gender reveal. You don't have to go to the christening or to your friend's house at Christmas when they've their beautiful new baby and you were meant to have a beautiful new baby. Mm-hmm. Say no. Step out of conversations you don't want to be in. You know, maybe have a little catchphrase that you say to people. Oh, thanks for the input, but, you know, we're listening to our doctor at the moment. Focus on yourself, and please, if you experience those feelings, don't beat yourself up. You're allowed to feel them, and if you're really struggling, reach out for support.
Okay, great, thank you. I suppose to Jade and Edgar, when you are working with people who are in the fertility hub, who are in, you know, maybe seeking kind of medical support, how do you deal with that wider picture of the emotional support that's needed, the psychological support?
Well, I suppose as midwives, we're very kind of in tune with that with people. We do have a lot of information, written information that we can give to patients as well, just in terms like for support. We also have a direct email service that we run for our patients as well, that if they do require support, we're happy to give them a call anytime. We're happy to speak to them over email if they prefer that. But we have referred people to the counselling service from the hub as well, especially I think with the discharge calls that we do when people have come back and their cycle hasn't been successful. We do offer a closure appointment with the doctor so they can receive medical support, and then we would also offer them the counselling if that's something that they wanted to avail of as well. I think we've seen a trend in the last couple of months, I suppose, that people are already linked with their own counsellors as well, which seems to be great that people have that support around them, but it is something that we will offer as well.
Okay, great. And Edgar, what have you seen in your own patients when you're working with them? You know, how do you support them through that emotional journey that they're on, as well as the physical and medical journey?
Firstly is discussing the findings of the tests you've done. I think the emotions are mainly stemming from the unknown. And if you can bring the information to the fore, if you can make them understand through verbal communication or maybe drawings exactly what is their condition, what is the reason why maybe a pregnancy has not established, and then offer a treatment and maybe quote some figures to give them some hope that a pregnancy will establish is the most effective way in my experience. But many times, some couples are really behind a hard shell. So it might take a bit of time till they start expressing themselves by crying and so on. And you know then that maybe you touched where it's hurting. And I think many of these couples do suffer in silence, I think. And although there are a lot of support groups, this is such an intimate matter that many of them might not even talk about. And it might be just one partner that is probably the soft part of the relationship that doesn't bring it up at any stage. So I see myself as the person that just cuts down to the bone and speaks what is important in that relationship. So yeah.
Okay, so, and you
it's
bring
not an easy position. So.
No, it must be, and I'm sure that you sort of approach each one on a case by case basis. But I think what you're saying is that the evidence that the tests can maybe show a path forward and cut away some of the unknown as well, right, that could be causing the distress. Absolutely. Any questions from our audience? Don't be shy. Because if you have a question, probably somebody else will want to know the answer to that question as well. Oh, Caitriona, you mentioned a bit of the sort of legislative landscape here. What's changing, and is it changing in a good way for people who are on a fertility journey?
Yeah, I mean, so the first committee that was put together to look at assisted human reproduction in Ireland was in the year 2000. It reported in 2005 saying that we needed legislation in this area, which would be really common for areas to have a framework and a legislation that gives guidance to clinics and practitioners and provides safeguards for people using it. The first piece of legislation was drafted in 2017, 13 years later, and it finally got signed by the President last year after lots of different different drafts, and a section about surrogacy was included. And basically what happened was the science just kept moving ahead and best practice kept moving ahead, and there kept on being redrafts, and it really just wasn't prioritized. So, I mean, it's now the legislation sort of sitting there in this strange limbo place where it needs to be commenced. So it's done its political piece. It now is kind of hovering for someone to flick the switch to turn it on to make it active. And that's really premised on the new regulatory authority being put in place, which is a key part of it. So, I mean, to provide guidance for clinics, for somebody who's had an experience to put in a complaint, to have an ethics committee, and just everything around it, particularly in more complex areas like surrogacy. You know, this regulatory authority is really important. We've been really keen to see it up and running. The board was announced just a few weeks ago, and now we're hoping that a CEO, etc., will be announced soon. And that'll be just a really, really positive step forward, because it then will allow the criteria that the hubs work within to be looked at. It'll allow for, you know, funding for different areas, new technology coming in, who looks at that, who reviews it, you know, legal requirements, everything like that. All of that is just sort of sitting there waiting to be actually mobilized. So, I mean, we're really hoping that 2026 will be the year that that gets stood up and moves forward. And it's everybody involved is very, very keen. Everybody from the clinics to patients, you know, to the HSE, everyone is working very hard to get this up and going. And we're the only country in Europe that really operates in this system without having sort of a guidance framework. So it's really important for everyone involved that we have that. And then we can do things like publish the statistics from clinics. What's the failure rates? What's the success rates? You know, everything like that. What new technology? I heard the UK recently had new technology or research going there, and was all led by their regulatory authority. And I thought, God, you know, we can't really even be looking at that because we don't have one yet. And I mind leading pieces of research around it. And like areas like this, they move so quickly. There is a lot happening in them. There's a lot of interest in it. We'd love Ireland to really, you know, be part of that and offer people that opportunity, but also that safeguarding framework for people working in it and availing of it is really important.
Absolutely, absolutely. And I mean, what you say there brings me on to an issue that I suppose could maybe be, people could accidentally fall into a position where they're seeing and reading some misinformation and disinformation about how to support their fertility journey. I'm curious to know, have you seen any of that? Have you seen people coming in and maybe they've tried things that maybe weren't good for their health, weren't good for their wallet, weren't good for their, you know, emotional state? Any of our panelists want to talk about? Yeah.
I mean, I do things like that myself, because you're in a very vulnerable position, and you know, you're hearing things like with lots of different things, and you think, oh, maybe I'll try that. And it was like Laura saying about, you know, the advice of that, like you have huge amounts of advice coming at you from all places, and you do start to do that self-stigmatizing thing where you think, it's me, it's something I've done, there's something wrong here now. So I mean, our advice, because as I said, we're not medical, we're not counsellor, there's always just to go back to your GP. Forget about everything else. Your GP will give you the best advice, because people will be looking at supplements and cutting out food groups and taking unwanted advice from people who have no experience in this area whatsoever. So yeah, but you do see a huge amount of that, and particularly this area lives quite a lot online.
Yes.
There's a huge amount of online forums and traffic around this.
Yeah, I can see Laura and Jade nodding there.
I have worked in the public sector for about a year now, but before that I worked in the private sector. And one thing that we would have seen is we would have just gotten a treatment plan in from a doctor. This patient is for ICSI. There would be no further investigation into the...
What's ICSI?
ICSI, sorry. It's intracytoplasmic sperm injection. And it's essentially where they take the best looking sperm from a sample and inject it into a mature egg.
Okay. Thank you.
And one thing that I learned when coming to the hub, and I'm sure Edgar is probably fed up with me asking him all the questions about male infertility, is that it kind of is skimmed over, and it's kind of, you see people that are going into private clinics and they're being advised for, say, an IVF cycle or an ICSI cycle without further investigation being done into why they're needing that. And I think that that's something that the private sector is really falling behind on, because we can definitely see the difference in the public sector, where we're investigating male infertility a lot more in terms of their bloods, in terms of genetic testing, in terms of giving men ultrasounds if they need it. And that's something that's definitely lacking, I think, in the private sector, where they're actually not looking for a cause and they're just kind of throwing these cycles at people who may necessarily could benefit from other investigations first.
And Laura, would you agree with that?
Yeah, absolutely. And I mean, like, we do have to remember that the private sector is for profit, you know. But yeah, and we'd see a lot of, you know, there's a lot of misinformation online, and that can range from things like eat McDonald's fries after your embryo transfer because then you're guaranteed that it will implant. That's a big one that goes around because of the 27 or 33 chemicals in the McDonald's chips. So that's okay. That one's maybe not that bad, but then you do see ones where people, you know, are making drastic changes to their lifestyle, where they become so obsessed with like clean living, maybe, that it impacts every element. And then, you know, that in turn, it makes them more stressed. You know, well, I can't go out there because, you know, they cook with olive oil, and if olive oil gets heated above a certain temperature, that's going to impact me. And, you know, and yes, that's true, but we also have to live. And so because we don't talk about fertility enough, people don't, like, we don't sit down in coffee shops and talk about it. So they get all their information online. And I would always say, like Caitriona said, like, your fertility doctor is the expert. Let them be the expert. Don't take it on yourself. You can do your research, you can make suggestions, but at the end of the day, these are medical professionals. Let them guide you as best they can. Because if you try to be your own doctor, you're going to make yourself a million times more stressed, but you also run the risk of potentially doing something that is harmful.
Okay. And Edgar, might you have seen people maybe doing things that maybe you'd say, maybe park that one? Have you any examples of people who've maybe seen that kind of misinformation online or heard it?
Sure. I do see a lot of people that are on a mountain of medication when they don't need it. I think the infertility field is a bit challenging for a few reasons. Females are born to conceive. That's why contraception is needed. So everything is there. The people that we deal with are the people that have failed the natural process for one reason or another. Furthermore, there was no education in relation to when is the optimal time for you to conceive. So if you're going to buy your fruit and vegetables at 5:45 in the evening in the market, you're not going to find anything alive there. And I think as a society, we have failed women and men to date. We have pushed the contraceptive side only, and we have not balanced the contraceptive education, which is necessary, with fertility education, and say to women and men, there's a career, but in terms of reproduction, it can't wait till your career is fulfilled. It has to be, particularly for women, it has to be ticked a bit earlier in life. And I acknowledge that there are challenges. I acknowledge that it's not difficult to find a man, as it's not easy. Sorry, it's not easy to find a man, as it's not easy to find a woman these days. But I think society, I'm always impressed by the fact that we call our system health system. It's not a health system. It's a nearly dead system. That's what it should be called, because we're only dealing with people that are nearly dead and we try to resuscitate them. A proper society will educate those young people to stay healthy, to eat well, to watch their weight, to make relationships, to study, to make babies when it's time to make a baby, and so on and so forth. So the difficulty for us is that when you've tried everything as a woman and a man to conceive and nothing has worked, you're at the most vulnerable place. Anybody can tell you anything. If it says you need to become an astronaut to get pregnant, you'll do it, because that's what anybody, a neighbor will say something, the paper says something, there's another Twitter that says something. So I think it's very difficult to be a patient with infertility. You're such a highly selected group of people that have failed all those opportunities to become pregnant, that there's either something seriously wrong from a reproductive perspective or from a life perspective. So personally, I believe that we need to make this a health system and not a nearly dead system.
Yeah,
and we should do
agree
that
with that
soon.
approach. Absolutely. So, I mean, what would be if you were to restructure how society thinks about fertility, you know, in terms of that focusing not only on contraception, but also on conception and the ideal time, not to be thinking that's just something into the future, but what kind of things should we be even encouraging young people today to think about? I mean, you mentioned things like eating well, keeping a healthy weight. What about things like vaping, which obviously is huge? Is vaping something that we need to?
Yeah, we did this. So the RCSI does a 14 to 17-year-old live session every year. And in fact, we do a talk in the other building called Making Babies. And it's a national thing where they all connect from all around the country, plus anybody that wants to come in. And it's a whole week where different specialists in the RCSI talk about their own field. It might be surgery, it might be endocrinology, it might be obs and gynae, and so on and so forth. So I talk about making babies. And I always ask these young people, 14 to 17, do they want babies? And of course, nearly everybody, boys and girls, by the way, it's full. Of course, everybody puts their hands, and then I ask how many, one, how many, two, how many, three, and you could see the vast majority want 2 or 3 children, yes? But I never had the opportunity to ask students how many children they want, or fresh graduates. And I bet that this is the time when they're actually the pressure of life, the pressure of performing, the pressure of finding a job takes family and the relationships and maybe planning a baby completely out of the picture. So if I had to target a population, it would be the students that I would like to give a talk. And ironically, I won't mention names, but I've offered to give a talk to all the students in one of the universities, and they never invited me. And I contact them again, don't ask for more money unless you give me an opportunity. They never contacted me. So it just tells you how education institutions are very resistant to discuss the fact that fertility is important. And it's an ironic scenario that that's the population we need to say there has to be a balance between delivering work after you've studied and being a citizen that works, pays taxes, and provides a service, and also having a family. And also the employers are at fault here too, because the employers sell the vision of freezing your eggs and so on and so forth. So what do you want to do with your eggs? Retire at 60 and go in and fit your Duracell packs and go in and have a baby? I think that's crazy. So I think that the employers should be forced. And in fairness, one in telecommunication company came to us and said, should we give women that have a miscarriage a day or two off? Absolutely. And they said, how many days should we give if they have IVF? And I said, give them a week. They need a bit of time for themselves. So women were given since then a week time off after IVF. So, but I think there should be a fine balance where somebody says, do you know what, I'm 32, I want to have a baby, would you allow me flexible time, would you allow me to, so on. So I'm very easy writing letters for my patients that work nights to say, you should not work nights if you're trying to conceive. And I give those letters to them because I think both the patients need to be aware, but also the employers need to facilitate that.
Yeah.
Thank you.
Yeah.
Sorry, I can talk a lot.
No, that's okay. And it is an issue that affects all of society, really. When you think about it, I mean, I'm just thinking, I'll take your question in 1 second, but I'm thinking of, you're saying, you know, that maybe at a time when people should be thinking about conceiving, they're possibly living at home with their parents because they can't afford to get a mortgage, et cetera, et cetera. We're not really set up, are we, for that at the moment? Jade, did you want to say something about that? Or no? Okay, you just handed you the.
Sorry, I might just pick that point out if you don't mind. Okay, I lived in a cottage. It's called the Tram Cottage in Clontarf. It had 1 bedroom, 1 hall, and 1 room. The families had 15 children in those cottages. It's only a myth that you need your own home to establish a family. Sorry.
The parents go to the cinema a lot or something when the kids are at home. What was your question? Elisa's just going to bring the microphone up to you. Okay, great. Thank you. Great question. Can you remind us what SPHE stands for the ancient people in the audience who didn't do it in school? Political. And educate, yes, but it's basic. Well done. It basically it's a course that for people in secondary school, it's about sort of life and society and health, isn't that right? And you're saying, is there an opportunity here to really sort of bring in more awareness about the importance of fertility and how to give yourself the best chance, I suppose?
Hi, thank you for the question. This was actually a concept that I had tackled previously. I was working in the delivery suite before I worked here, and a couple of the midwives there had looked into doing courses in terms of sexual health and sexuality. And then the plan was to try and educate or go into schools and do like sexual health education, but not in the way that it's done in society, in a way that kind of teaches children about their reproductive health rather than scaring them away from learning anything about their reproductive health. And one of the midwives that I worked with had actually reached out to some schools and it was not accepted. So I think that's something that needs to come more from a government side of things, and something that needs to be totally restructured in terms of what we're teaching teenagers and young people in society about their health and how we're addressing it. Because you can sit there and you can learn complex things about maths and all of this, but you don't know anything about your body. And I think it's very much a shame to society.
Yeah. Any of the other panelists want to come in on that? Caitriona?
Yeah, and yeah, I would agree with that. And I think something needs to be framed in terms of a choice. People, because we tend to kind of frame it here as one of these things that just kind of happens through life and it'll all just happen. But people make choices in life, and having a family is a choice. And if it's a choice that you plan on making in the future, like when you're younger, you think, I think I'm going to choose to go to college. When you're in college, I think I'm going to choose to have a career in this. And another choice is I would like to have a family. And it's to frame it as in not just take it for granted, because I think that is sort of where we've come from. And we need to learn that you make a choice and then need to put the building blocks around how that choice actually happens. The other thing I just want to pick up on is Edgar's point around employers. That's a huge thing as well. If you were a teacher and you're standing here and you're in the middle of an IVF cycle and that clock says at 12 o'clock you need to take an injection, but your class doesn't finish till 12:15, what do you do? And then you're trying to get your little bag out of the staff fridge that has your your injections in it because they need to be kept cold. You're running down to the toilet, and hopefully a toilet will be free, and you're trying to give yourself an injection in the toilet. And that is what a lot of people are doing in workplaces, and it really adds to the stress of it. They don't want to say to their employer, listen, I'm going through this, because the school principal is thinking, well, I'm not offering them a permanent contract now because sure, they're going to be gone on mat leave next year. Like, it really has big consequences for your career. And, starting a family is nobody's business but your own. So you don't want to start having these conversations with different people in your workplace. But it's another function that the regulatory authority could really be part of, is, that there would be guidelines. Everything doesn't have to be legislation, but you could put good guidelines in place around giving people flexible options to work from home when they're going through treatment without having to disclose what extent of treatment they're going through. And if they've had the news they didn't expect around a cycle, again, even being able to work from home, or if it's coming up to a particular day in work, like there might be a family day or a children's day around Christmas, perhaps that day they could also have some flexibility. But on one side, employers don't know what they don't know, but we need to give employers that information as well, so that then they can put better structures in place for their employees. And employees that get that from an employer, you create these really loyal employees, because you support an employee when they're going through a tough time. An employee will support that company back.
So, Laura, you're nodding your head there.
Yeah, absolutely. And I've seen, real life examples of women who will change jobs because the company they're going to has a fertility policy. And Caitriona's so right. If you are going through, say, an egg collection cycle, that is stressful in and of itself. You're probably going to be bloated. Your hormones are being ramped up. And if you even have the flexibility to work from home, it makes the world of difference, because you're not worried about the Lewis. There's been a car has hit the Lewis, and so now you're late getting home. You're going to be late taking your gonal F or your Certitide, and because the medications, people really get it into their heads that they have to be so mindful of the medications, that when we give people flexibility, it makes life easier for them. And therefore, we have a society that functions better. And I think just in relation to the question, great question, Kiva. Yeah, it is, you know, we need to be, like we were talking about this beforehand. In school, it was kind of like if you looked at a boy, you'd get pregnant, you know, and then you try to get pregnant and it's like, oh no, actually, no, I can't. So we need to be a lot more open with the conversation. And I think that needs to start with how we communicate with kids as well. You know, we tend to hide children from all aspects of life, but you know, like they witness things. If mum and dad are going through an IVF cycle, like they'll know that something's up with mum and that the fridge is full of medication. And okay, so you're not going to sit down and tell them exactly what's going on, but you know, it's okay to be like, you know, mommy and daddy, we just need a little bit of help from the doctors. And so that's what we're doing. And I think if you started at a young age, you then build a society where fertility is no longer taboo. And that has to be beneficial for all of us.
Absolutely. Yeah. I was encouraged to see there, the Irish Times has a podcast, Conversations with Parents, and Miriam O'Callaghan was on, and she spoke very openly about having secondary infertility, which was something that I hadn't been so aware of. So is that something that you encounter a lot in the Fertility Hub? That secondary infertility?
Definitely. On the 30th of June this year, the criteria changed that secondary infertility. So if a couple have one living child between them, then they weren't in the past eligible for fertility treatment in Ireland under the government scheme, but now they are. And we had seen an influx because we always keep an open line of communication with our patients, so they all had access to our email. And we seen an influx of patients coming back that were entitled to care, that were able to be pushed straight through to a clinic. So we are now keeping a record at the moment of how many referrals that we've made for couples who are suffering with secondary infertility. I think we're on 35 since June, just secondary alone. So there's definitely been an increase of what we're able to do for them and where we're sending them. Yeah.
And isn't it amazing how by widening the criteria, you enable more people to benefit from your services? Edgar, did you have anything to say about that?
Certainly. The older the female having the first child, the least likely she's going to have another one. So that's one of the reasons why secondary fertility is on the increase, because the average age of patients we see is 37, 38. A female's chance to get pregnant at 37 is 10% per month. 10% per month means 90% you will not get pregnant. Yes. So this is where we're on the dead bed, not the healthy bed. Conception is younger than 30. That's when everybody builds a career and they're not thinking about a child. And there's a very interesting paper published that says that if you want to have 3 children with a 90% probability, you have to have your first child at age 23. So there's some biology that is at play. So the older you are having your first child, the more difficult it's going to have your second, the more difficult it's going to have your third. But this is in patients that we see. You have to remember that fertility patients are not what is happening in society. Some women can have babies, as you said, the man just looks at them and they just have baby after baby after baby after baby. Even when they're 45, they might have a baby. Yes, but it's not for everybody. So this highly selected group of patients are the ones that have something that makes them be in a worse place to conceive. So having a second and third child will be even more difficult.
It would be more difficult.
But definitely we see a lot of patients that have one. We have also to look at what is happening in terms of work. Work has become more stressful, more pressure on people. Yes, maybe commuting. I see patients that commute 3 hours every day. If you drive 1 hour and a half and 1 hour and a half, do you really have time to go home and do dinner and wash yourself and make love to make a baby? I don't think so. Yes, so we don't really look at the bigger picture of what is happening in our societies. And this is where I think the role of a society is. We're not here to facilitate a chance to get pregnant with IVF. We're here to change the picture completely. Mm-hmm. We have the way you change this piece of paper there and you paint a new
Robin's work
painting, yes, it's the same way what our society needs to do. So the solution is to educate people and say contraception, yes. Becoming pregnant when you're an adolescent is not good. Not good for the woman, not good for the child, not good for anybody. So to take contraception. But at the same consultation, you need to be told, don't leave it too late, because when you're 30, your chance to get pregnant might be only 20%. When you're 35, it's going to be 10% per month. When you're 40, it's going to be 5% per month. So why do you really focus on one side and not think of the other? And I agree completely. It's a choice. Having a pregnancy is a choice. It's a punishment for the woman. The man is a bit more, okay, you need to be there. You need to care for the child, bring it to school, do the dinners. You know, I mean, I could never understand why women wanted to be equal to men. Did you? I could never understand. By birth, women are well above men. A man doesn't carry a baby, doesn't deliver a baby. There'll be no babies if men will have to deliver babies. But, you know, doesn't have to run a house, doesn't need to do dinner, doesn't need to go shopping, doesn't need to go and do the work and all that stuff. So women are well above. Yes. So I think that we need to, if I be a politician, maybe I will be one day, I'm going to say that women should work for 4 hours and be paid for 8 hours, because they do for the rest of the 4 hours the work that men can't do.
Well, I will vote for you.
Thank you.
Jade must look at you. She only have to work for 4 hours tomorrow and get paid for 8.
And we should cut down taxes for couples that want to have a family and they cannot make ends meet. Then we should give zero interest mortgages for anybody that has a job.
Edgar, you've got all the votes now.
That's how you convince people to say, oh, maybe having a baby is a good idea.
Yes, creating a society that enables it more. Absolutely. Caitriona, did you want to come in?
I was going to say, I think women don't want to be not equal to men. We want to be treated equally.
Yeah, yeah. There's a nuance there. Absolutely. Before we round up, does the audience have any more questions? Any more questions from the audience? Okay, no problem. Sarah, you have a question.
Yeah, sorry, I'm trying not to be shy, so I was like, I'll be brave and ask a question. Just about 15 or 20 years ago, I noticed kind of the landscape was like a lot of people just didn't talk about fertility, and they didn't like to tell anyone they were pregnant for a long time, even if they were. But and even when people first started going through IVF journeys, the first and third and second, or first, second and third round, they'd finished, and they wouldn't try again because of the expense involved. And I'm noticing once that happened, a lot of people would withdraw and they wouldn't really want to discuss it. And it's such a sad part of our society. But however, I have noticed there's some sort of improvements that people are more willing to talk about it. And I'm wondering, is there a limit into how many rounds of IVF that people are offered before they're recommended to stop? And I obviously would love there to be less of a taboo, and that has become a bit more, but I do wish that atmosphere was there back in the day. And I'm just wondering, is it when like older women potentially are looking to get IVF, is it less recommended when you're older? So it's kind of two questions. How many times are recommended to do IVF before you stop? And then if older women get IVF, is it as recommended?
Thank you. Thank you for those questions. Edgar?
So if you're asking how many cycles of IVF the HSE funds, the answer is they fund one cycle of IVF. That means the eggs are taken out, embryos are created up to the moment when a baby is born. So if the woman has a child before she uses all the embryos from that one egg collection, then she needs to pay for the rest. Okay. If you're asking the question, when should we tell a woman that we will not provide IVF, even if she wants to pay for it, that depends on many factors. Ability to collect eggs or produce eggs, the age of the female and the male, the quality of the embryos, and what has happened in the previous treatments. So I think we discussed emotional aspects here. Usually on average, 3 egg collections will be a lot in terms of physical and emotional burden. So there are countries that offer unlimited number of IVF treatments. I'm not going to mention, there's only one on the planet. But I don't think personally that it is physically and emotionally wise to continue when it's nearly evident that it's not going to work. Is there a certain age where a woman or a man should not consider a pregnancy? And that's a difficult one to answer. But we have very good evidence that both the female age and the male age contribute to the health of the child. So primarily we'd like couples to consider a pregnancy when they're young, and certainly before 40. But it is still possible to conceive maybe up to 45. To give you an example how nature selects out a woman of 45, doesn't matter if she conceives through IVF or spontaneously, has a 90 to 95% chance of miscarriage, because genetically those embryos are not healthy. And we also have evidence that the older the man is, even if the woman is young, the health of the child will be affected. But then there's the dimension of the female health, and I'm finishing with this. There's the dimension of the female health when she's pregnant. So one thing is to become pregnant and have a baby at 25, 35, 40, a different thing at 45 or 50, where you have a higher risk of diabetes in pregnancy, a higher risk of high blood pressure, a higher risk of a clot that goes to the lung and places you at serious risk of dying, a higher risk of all the complications of pregnancy. So there's a fine balance between, the medical intervention should aim to have at the end a woman that is alive, a baby that is alive and hopefully healthy, so they can enjoy a long life together. But the older the female is, the risk of complications increases. Thank you.
Okay, thank you. Thank you for the question. I want to finish up by asking each of our panelists for their top takeaways for people about the fertility journey and the support on it. So maybe Edgar, will go back to you. Top takeaways for people about the fertility journey?
I think I didn't ask who the audience is, and I wouldn't ask who they are. But I think the top message from me as a practitioner is that we have a duty. We have a duty to educate and talk to the young people. We have a duty to talk to employers. We have a duty to talk to politicians about the need to respect the desire of some people to want to have a baby and some people not to want to have a baby, and treat them equally and provide what is needed for them to be inspired to have a family, as opposed to not see the benefit of having children around. Thank you.
Thank you. Jade, what's your top takeaway?
I think one thing about a fertility journey is that when you're at the very start of it, the more that you know, the better. And I think that as much as it is your love of your partner and you want to have a family, being informed of where you stand before you're 2 years down the line and struggling is a really good place to start, because at least you know then that you're 2 years ahead of if there is a problem. Another big thing I hope that people will take away is that the hub is not your only route to having a baby, and what we offer is not your only route to having a baby. There's many other ways to achieve a family. There is donor conception, whether it's egg or sperm, whether it's private or whether it is abroad. As much as we would love to be able to provide that care within the HSE, we are bound in the Rotunda by the HSE policies, but there is many, many ways for you to create a family, and it's not just the one IVF route. There's many different ways to do it.
Great, thank you. Laura?
So I think my main takeaway would be that a fertility journey can be really hard, and what you feel is what you feel, and that's okay. So to treat yourself with kindness, compassion and grace, to also show the same to your partner. If you are struggling, reach out for support. That's what we're here for. You know, there's lots of, whether it's your fertility doctor, your midwife, your counsellor, NISIG, there are supports there. We do want to help people. And where possible, stay off social media. The influencers don't know as much as the medics do. So please listen to your doctor and not the influencer who's telling you to stand on your head every day and take 52 supplements.
Okay, thank you. And Caitriona?
That's great advice. I think mine would be that you're not alone. It can feel like a very lonely time in your life. It can feel like a very lonely journey. Someone else said, you know, we're not sitting around in the local coffee shop or in the pub talking about this, but there are thousands of people going through this every year. And there are supports out there, and it is well worthwhile reaching out and getting support. It does make a huge difference. I know myself, it made a huge difference to me. Just we're all looking for people that we're like in any stage of our life, in our career, you know, and what we're doing. I'm like them or they're like me. And, you know, then when you feel utterly alone and everybody else is doing something that you want, because you tend to hit this time in your life when you and your peer group are all kind of in the same time, you can really struggle with it. And sometimes it can be hard to talk to your partner because then you end up in this cycle of always talking about this one thing. So it is good to have somewhere else to go. And as we were saying, there are some supports out there, and I really encourage reaching out. Just my own experience, I know it made a huge difference.
Great. So thank you so much, everybody involved in today's discussion. I want to thank Orla for doing the ISL interpretation and Robin for doing the visual interpretation. Amazing work. I want to thank everybody involved in the Bias Festival. So Eliza, Zara, Holly, the volunteers, Laura and Zetty, everybody's just been wonderful to work with. Of course, thanks to Research Ireland for supporting Science Week, and our panelists. I mean, we've got Edgar, Jade, Laura and Caitriona. Couldn't get better than that. And thank you for coming and giving us your time today. Thanks, everybody.